Thank you very much for the invitation. I'm particularly happy of what I'm hearing about breaking silos, because I've been fighting against these silos for nearly 25 years. So I'm not specialized in tropical diseases. I'm not a dermatologist. I'm a rehabilitation practitioner. And that's how I got to skin disease. The idea is that wounds in low-resource settings are quite of a problem because they are linked to the traditional neglected tropical disease, but they often occur on traumatic such as accidents, burns, violence, snake bites, and we have newcomers coming. That's diabetic foot, venous and arterial ulcers. These we know quite well in our countries, but they are going to be spread in the next decennies in low-resource settings also. So when I began to collaborate with Doctors Without Borders, that was 10 years ago, around the Burley ulcer, we saw that the wound care was of low quality. If we could have a resume, the wound would be left to dry as much as possible. The disinfection was conducted at a very long term, and the people, the caregivers, had no knowledge of real wound healing physiology. So the dressing are made daily, they are painful, and at length they are costly. And then for the rehab practitioner that I am, we see that in some lesions such as leprosy, Burley ulcer, for example, and others, burns, there is nearly no disability prevention. So this is an illustration where you see, for example, these dry dressings. Here you have the flesh that's growing inside the dressing, and of course when you remove it, it's painful, and you take off what the body has produced in the last few days. If you see these pictures, you see how people will get disability. And this one is a very good illustration, because this poor guy, we can say that the treatment is conducted quite well. We have closed the skin. But then is it really useful, as this guy cannot put his foot on the ground? So that's one thing we must think of. Just to present the work, the idea is to promote sustainable prevention and care of wound and lymphedema in limited resource settings. That's a nice phrase. That's much more difficult to do. But we are here and we try to raise awareness of the importance of chronic wounds and lymphedema to contribute to global policies and to develop the locally needed capacities. And I think many of the speakers have spoken around these locally needed capacities, and that's very, very important. And then we try to foster and support research whenever we can. One action we had is the publication of this small book in 2010, and it's under revision. And it's the first time that WHO has a publication that's centered on wound and lymphedema management. The book in itself is not a very good manual on the field, but at least all the components of modern wound care are in this book. And you can get it free, download it free from the WHO website. And I saw with pleasure that in the maps you have the whole address to do it. What we try to teach are very simple things, and we have 6 basic principles, which are to evaluate and address systemic conditions. That's very important. If you have malnutrition, if you have an infectious disease that is a cause of the wound, then of course you have to treat it. Then you have to protect the wound from the trauma. That's very important. And one of the trauma we never think of is disinfection. And we have learned that these wounds must not get infected, so we use lots of disinfectant, and sometimes we use them at stages where they are useless and counterproductive. Then we have to debride and control wound infection, and the most important is to maintain a moist wound environment. And that's against what we think since quite a few centuries. But think of it, a wound is a biological scene. If you want the biological process and the cytokine thing to get the wound to get healed naturally, then you have to keep your wound in a moist environment. You have to control peri-wound edema and lymphedema. And that's something when you have a huge lymphedema, like in filariasis, of course you think of it. In our countries, when you have venous leg ulcer, you know that contention, compression is the treatment. But it applies to all wounds because all of these wounds have a local peri-wound edema that you don't see often with your eyes, but you can be sure that they contain pro-inflammatory cytokines, which are very useful in the beginning of the process of healing, but are useless in the next days and weeks of the healing. So you have to think of it. And then you have to prevent disability whenever it can occur. Another action we have is a new basic dressing kits. You know that most international organizations and NGOs use this type of kits, which are standardized, prepackaged. It can be sent, and you know for how many people they can be used. So we know there is a cholera kit, reproductive health kit, interagency emergency health kit. And there is a dressing kit which is now 30 years old and doesn't englobe the new way of thinking about dressings. So the most important items we think should be in this kit is soap, dry gauze, Vaseline, alimentary plastic film, tape and bandages. So you see it's nothing very fancy inside. Well, of course, we've put a little iodine and silver sulfadiazine because it's also useful, but it's not the main thing we want. And through this material, we hope to provide, of course, basic material to do wound dressings, but to change the way dressings are made. And that's the most important part. Then we are doing grassroots teaching. We have various experiences. I think the most constructed is done now in Cameroon, in Yaoundé, where for 4 years we had a yearly course which consists of 3 to 4 days of theory, skin physiology and wound healing physiology, anatomy of course, wound lesions, differential diagnosis, of course it's useful, the treatments including rehabilitation, and it's filled with workshop where people make wound analysis on pictures, they make dressing, they make bandaging, they make compression therapy, debridement, and also hand and global hygiene. And then they go to the Akonoliga Hospital, which is around 120 kilometers from Yaoundé, where a team has been taught now for 10 years on modern ways of dressing, and they couldn't do practice. What's very important to me is that from the beginning, 95% of the teachers were from the country, from Cameroon. The 5%, it's me. The attendance and the teaching team is interdisciplinary. Of course, we have doctors and nurses, but also physiotherapists. We have psychologists, and then sometimes we have people that are other health professionals. This is done in partnership with the MOH and the Yaoundé University, and in the future we think that we'll have to make a small team that could delocalize the teaching and the training. Why do we have these people coming to the Akonoliga Hospital? It's because we know there the team is used to this, but we could send people to their own hospital. So they would do their training on their spot of work, and they could do the implementation of the new techniques, both in one time. And then we are asked to give a more complete wound care course, and probably that will be the future, not for all the trainees, but I don't know, 1 out of 10. But the basic course, the people can get back to the hospital and then practice and give something more to their patients. And then just a word on the CRS, which is the International Center for Research, Teaching and Care. This is a small Cameroonian-based NGO with European support that has been created just a few months ago. And the idea, just as in the title, is to help on research, to have people wanting to do research, and so they get a local structure. They have no needs to, you know, when they get at the airport, they have a contact and somebody comes and they have a house and things like this. And also to have our own programs. And then teaching the course, as I showed, but have students from Cameroon and elsewhere coming to this small hospital in Akonolinga. And of course, care, because patients will directly benefit from this dynamic move. And that this is the Akonolinga Hospital and a few pictures of what's done over there. So if I may conclude, modern and efficient wound care is possible. Some of you may know of the modern wound dressings that are sold and are very expensive. They work quite well, and 10 years ago we used some from Johnson & Johnson. It works quite well, but with the price of one dressing, you will feed your family for 1 or 2 weeks. So that's not sustainable. And if I come back to the kit, you see that what's inside the kit is much less expensive, and most of it can be replaced by local things. For example, Vaseline can be replaced by shea butter, by palm oil that you can provide just on the market. Then we must train local teachers. It's not a thing where we go and we do. It's we go and they learn, they do, and then they go and they go and they go, and it snowballs. The 6 basic principles are really ideal for this training. And then just one word on interdisciplinarity. I think it must be favored. Interdisciplinarity is something we have now quite of a culture. Everybody speaks of it. It's sometimes a little more difficult to do it, but it's very important. And I have some example where you had different resources, doctors, nurses, physio, people making shoes, and they wouldn't work together despite being in a 50 meters diameter in the same hospital compound. And they learned to work together, and now they are much more efficient. Thank you very much.